What's going on, everybody? Welcome back to another episode of the Cortisporin RX podcast. Cole, what's good, man?
Nothing much. I'm actually kind of frustrated this evening.
Oh my gosh, why?
I have a little a war going on in my house.
Ugh.
But it's really outside of my house. It's with moles.
Moles, oh yeah?
Yeah. Terrible.
Tearing up your yard?
Tearing them up, dude. Last year, it was just the backyard, and it was a constant battle, but, people can't see the backyard, so it's not a big deal. They moved to the front now.
Yeesh.
Yeah.
Get those little pellets you put in the ground?
So I tried the pellets. Pellets don't work. So I asked the professional people, how much. They're like, oh yeah, it's $400 for this amount of time. I'm like, that's crazy. Well, what do y'all do? They just take the mole worms. They're worms, poison worms, of course. And they treat it. They come back a month later, see if the moles are still alive. If not, they treat it. They just put worms out. So I just bought the worms. That's what I put out.
Nice.
So we're going to see if I can murder some
actual
moles. No, they're not real worms.
Oh, okay.
They're like...
they look like worms.
It's like a literal gummy worm,
Oh.
but poison. So you want to keep
don't
those away from...
Don't get those mixed up.
children. Right. But yeah, it looks like a large gummy worm.
Yeah. Have you ever seen a mole? They're very weird looking.
Well, yeah. I mean, my dogs would, dig up the yard and kill them when I was a kid.
Yeah. They're very strange looking. We found one time, and I was like, we should keep this thing as a pet.
I see.
Back when I was a kid, my mom was like, no.
Oh, it was alive.
Yeah.
You found it in the yard?
Yeah. And you look, I was like, this is the weirdest looking thing ever. We should put this in the house.
The weird looking ones are the ones with like the star nose or whatever.
Yeah.
It's like they have a hand on their nose.
Yeah. I don't like that.
Yeah.
They need to keep that to themselves.
They do.
Yeah, no, my mom was like, no, you're not obviously keeping a mole in the house, which is weird because I had a lot of weird animals growing up, but mole was like, where she drew the line. She's
not
like,
going to happen.
Also, probably wouldn't be a very good, you'd have to have a monster enclosure or something like that for him to dig around, I guess.
Yeah, and I guess you'd have to be able to see him kind of like a ant farm, so you can see his tunnels and stuff.
That would be awesome.
But otherwise you can't see him.
He's just looking to the side like, what the heck?
You have to get a tinted one where you can see
two-way
through it.
mirror.
Two-way mirror.
That would be cool. That's okay. Well, I guess I know what our next project is going to be. Don't tell Jen. So what are we talking about today?
Well, I was going to ask you, did you used to have ear infections a lot when you were a kid?
I did get, quote unquote swimmer's ear, which we'll talk about. Yes, I got that a few times. So yes, unfortunately, it wasn't something I had to deal with a lot. Like I didn't have to, ever have like tubes or anything put in, but it was definitely something that, I guess I just wasn't good at getting water out of my ears when I was younger.
I don't recall ever really having them. I guess it might have been pre-memory, but yeah, I mean, I had friends who anytime they went swimming, like they're going to have an infection. Or they're going to have some issue, right? Swimmer's ear or whatever.
I remember one time being like, my mom made me do these like swimming like classes when I was like, I was really young. But she was like to teach you the different like strokes and stuff like that. Just which everything every 5-year-old wants to learn. And I was like, I had a swimmer's ear infection or whatever. So they made me put that wax in my ear. And I just remember being like, this is not a good look. Like at that, And I remember like just looking around being like, yeah, nobody else has wax in their
You're the
freaking
geeky kid with the stuff.
Dork with the stuff in my ear. There's no way to look cool with this.
I remember the swimming lessons, but mine were more like my dad literally forcing me under the water and then me screaming and grabbing at him to try not to go into the water, so you can learn to breathe underwater because you're terrified.
Yeah.
And I just remember, basically being traumatized because I was almost drowned being forced under the water.
Yeah, no, that's good.
But then I learned to swim, so
it all worked out.
Yeah.
Thanks, Dad.
Thank you, Dad. But yeah, that's what we're talking about today. Two different types of ear infection. So Otitis Externa and the more well-known Otitis Media, I would think.
For sure.
Yeah. So where do you want to start with this?
I guess just some quick background information. Basically, we'll start from the outside and work our way in. So Otitis Externa, basically just this diffuse inflammation of the external ear canal, and that may or may not involve the tympanic membrane, depending on how bad it is. So a lot of times patients will kind of show up, they'll have, inflammation obviously in the ear canal, but also usually like itching, maybe like a feeling of like fullness. Sometimes if it's bad enough, it can even have like jaw pain associated with it. Temporary like hearing loss can also be an issue. Otorrhea, so basically, drainage out of the ear. And then even like redness and swelling on the tympanic membrane itself. But usually the symptoms, especially from a pain standpoint, kind of kick in within 48 hours of the infection. And then a lot of times too, the patients will have some kind of history of like recent water exposure. Other times patients will have maybe a history of like local trauma. And then they also could have like almost like an allergic component to like patients with eczema and things like that can also kind of make them more susceptible to it. But a lot of times otitis externa, you'll hear kind of like commonly referred to as swimmer's ear. So I always think of it as, patients who are spending a lot of time in the water. So a lot of times you see this in kids, spending time in the water and whatnot, and they're not getting that water out of there. It's allowed to kind of, the bacteria gets stuck down in there and allowed to kind of grow and turn into an infection.
Yes. So it is an infection, and there's common bacteria associated with it. So you'll recognize these, one, Pseudomonas, and also Staph aureus. So those are two common bacteria that cause the otitis externa. It can be caused by other bacteria or a combination of multiple bacteria at the same time, and it can be fungal. But Pseudomonas and Staph aureus are common ones. Like Mike had mentioned before, you can have issues with hearing, so hearing loss, and that comes from or can come from narrowing of the external auditory canal. It can become more severe. It can affect the soft tissues and even bone, and you might call that malignant otitis externa. It can be classified as chronic. So chronic externa would be defined as it being there for longer than 3 months. This could be a psoriasis type situation, an allergic issue like Mike mentioned before, eczema, or if it's just not adequately treated, acute otitis externa that lasts longer than 3 months.
One thing interesting about that, the malignant OE, like you mentioned, where it's kind of extending into that soft tissues or even the bone, 90% or so, depending on the statistic you're looking up, 90% or so of patients that actually experience that have uncontrolled diabetes. So that's
Makes
one
sense.
of the things that's especially obviously in older patients, when the patient is uncontrolled, uncontrolled diabetes, it may kind of change up how we treat the patient just because that seems to be a complication specifically, in that patient population. So the good thing about treating otitis externa is we don't have to put the person on systemic antibiotics in most cases. So typically we're going to use a topical eardrop antibiotic and usually a combination. And then typically what we do is we use either an antibiotic or two antibiotics together with a combined corticosteroid as well. So a very common, just to kind of lay out a few, none of these have been shown to be necessarily better than the others as far as efficacy, but just to give you some common treatments that you'd probably run into, you could do things like the cortisporin, which is the neomycin, polymyxin B, and hydrocortisone combined. And there's actually two different forms of that too, just to kind of mention. There's the suspension and the solution. And I believe the suspension is actually known to be less irritating than the solution. So they come, I can't remember which manufacturer it was, but there was one that was a green box and a blue box, and they were all identical except the fact that one was the suspension, one was the solution. I remember as an intern.
The Paragrow?
Maybe. That sounds familiar.
I'm not sure. I can't remember.
But I remember being like a tech. I think it was a tech. I don't think I was even an intern at this point. But I remember being like, I know what the difference between those two are. No big deal. So that was like a point of pride for me in my pharmacy. But so that's one option. There's also some combinations with ciprofloxacin. So there's the Cipro HC. So ciprofloxacin, and it's the 0.2%, and then hydrocortisone. That one I haven't checked the price in a while, but I believe that one tends to be a little bit more pricey. There's also another ciprofloxacin that's a little bit more concentrated, so it's 0.3%, and it's in combination with dexamethasone, 0.1%. That one's called Ciprodex.
And it's still expensive, but it went generic last year, so
Did it?
price should be coming down. Mm-hmm.
That's good. And there's another one that I want to mention just because I think it's something you probably will see. And it's called Cortisporin Cortisporin. I want to make sure I say the name right. Cortisporin TC, I believe. I'm looking this up in real time so you guys can feel like you're a part of it. Cortisporin TC, yeah. So it's the Thonsium. It's like the original, the neomycin. This one has colistin in it instead of polymyxin B, and then hydrocortisone and Thonsium. So it's a little bit slightly different. I haven't seen any additional benefit. In fact, the Thonsium ingredient itself, I've looked up and it doesn't seem to be correlated with any additional efficacy and cure rates or anything like that. And I do know the price is significantly higher for that one compared to regular Cortisporin. So if you happen to see Cortisporin TC, especially if it's an uninsured patient, obviously be aware that it may not be all that more effective.
And for a standard patient, you're going to get a good response from any of these anyway.
Yeah, exactly. So those are the combo products that are pretty common. There's others, I know they're out there, but those three are pretty common. Then we also have some alternatives, like we have ofloxacin by itself. And then we also have some aminoglycosides like tobramycin and gentamicin that are available as well, kind of as singular products. There's also Volsol HC, which is acetic acid and hydrocortisone, but we'll talk about that one again when we come to fungal infections. The big question obviously being, is the steroid that's a component of the combos needed or of benefit? Is it harmful? All those type of things. And there's been studies that have looked at antibiotics versus antibiotics plus steroids. And that does seem to correlate with the same cure rates, regardless of the steroid being present or not. However, the symptom relief, so that relief from pain and whatnot, is going to be achieved about a day earlier if you use the combination. So something to keep in mind. Obviously, if it's an adult who doesn't care and price is a major driving factor, ofloxacin by itself without the steroid is going to be just fine. It's going to treat the infection, and it's definitely much cheaper than something like Ciprodex. But just something to kind of keep in mind. It's not the end-all, be-all to have a steroid in there, but it does make the symptoms go away quicker.
Right. There are some special considerations with these. The state of the tympanic membrane can be important. So if you have a tympanic membrane perforation, a lot of times primary care providers will use ofloxacin, but you may see otolaryngologists use Cortisporin or Cipro-HC. If it's still intact, so there's no perforation, aminoglycosides can be used. A good trivia question for pharmacists that they like to throw around is that there is a difference between eye drops and ear drops, but eye drops can go in the ear, but ear drops cannot go in the eye, and that's because the eye is sterile. So if your eye drops are already sterile, they can go in the ear, but the ear drops are not made the same way, so it would not be safe to put those in the eye. And interestingly, some eye preparations are better tolerated than ear preparations as well. Severe cases may require using a wick.
Yeah. Kind of going back to what you said about the primary care versus specialist. I saw a study that just recently, it was from a few years ago, but it was new to me, where they were kind of looking at that, and it looked like even with tympanic membrane perforation, there was not really any additional danger between using a steroid or not. And so some of that fear from the primary care setting, you only wanting to use the steroid and not the antibiotic, not the steroid, seems to be something that's kind of been grandfathered in, but not necessarily needs to be in modern day, medicine.
So do you want to avoid aminoglycosides if the tympanic membrane's perforated? So
yeah, that's the case. Because of the ototoxicity, even topically, we do try to avoid aminoglycosides. But if it's a steroid and you have some tympanic membrane perforation, you don't have to necessarily avoid the steroid.
Gotcha.
So yeah, but the aminoglycosides for sure.
Yep.
And that wick is pretty cool looking. If you guys haven't seen it, you should definitely Google a picture, because it looks like a little piece of cotton. And it's basically all it is. It expands whenever it gets wet. So it puts the drops directly on it. It expands, opens up that ear canal, and allows the drops to get a little lower in the ear. But yeah, obviously we can't show you a picture of it right now, but take Google and Google the image and take a look. It's pretty cool if you haven't seen one. All right. So what about systemic antibiotics for initial therapy in otitis externa? Now, in most cases, like I said, we can use topical antibiotics and then be just fine. There are some cases where we may need to initiate systemic antibiotics, one of which being recurrent infections. Maybe the patient is just incapable of kind of getting the drops deep enough in the ear. Maybe it's the wrong antibiotic. Whatever the case may be, they keep coming back. Let's maybe consider systemic antibiotics at that point. Also severe symptoms. In some cases, if the patient's having, just really, really bad reaction, like, pain, really bad inflammation, maybe they're affecting their hearing, or we need to do something a little bit more drastic, maybe then systemic antibiotics would be a good option. If there's any kind of extension beyond the external ear canal, obviously we're thinking initial therapy with systemic antibiotics in that point, because that's more of the otitis media at that point. Or patients with poorly uncontrolled diabetes. So if you have a patient that's has a really high A1C, it's not been controlled for a little bit, they're going to be the highest ones that are at risk for that malignant OE, like we talked about earlier. So those would be ones that you really want to make sure you nip this infection before it gets worse. And then same with immunocompromised patients. It may be something to consider systemic antibiotics in them. Doesn't mean that every one of those things we always are going to use to systemic over topical, but those are some scenarios where you might want to at least consider systemic antibiotics.
Yep. So next we're going to tell you how to properly administer an eardrop, which is a good counseling point for pharmacists and for people prescribing it. But I can just assure you there's no way that patients do this correctly every time. There's just no way. So apparently it can work without doing this perfectly, but it's good to let them know how to do it. So one good thing is to tell them to warm the bottle before they administer. So warm it by rolling it in your hands, because if it's too cold, it can be painful and even cause some dizziness. So, just an additional side effect concerning in elderly people for sure. Have the patient lie down or tilt their head at least, so the affected ear faces upward. Use the drops to fill the ear canal, and then keep the ear facing up for around 5 minutes. That's the part that I'm sure people don't do all the time.
Yeah.
5 minutes. And do not touch the dropper to any surface, or it can contaminate it.
Especially since there's not going to be the same preservatives like in the eye drops.
Right.
So it's very easy to contaminate comparatively. So
right.
Not great. Just keep on giving them more and more bacteria back in the ear. It's not ideal.
Switching out the bacteria for different bacteria. Yeah.
All right. So in the case of a uncomplicated fungal otitis externa, so this may be something that comes up where, it's maybe you've treated with antibiotics, is not going away, and there's a lot more like itching and things like that associated with it. It may be something to consider that it's a fungal origin. So treatment-wise, we could use the acetic acid and hydrocortisone combo that we mentioned earlier. And acetic acid does actually come as a product by itself. And there's also a clotrimazole solution that's Lotrimin that comes as a drop that you can use in the ear. And so either of those options would be good. The acetic acid hydrocortisone, because as the steroid, would be something to consider. Now the thing is, if it becomes recurrent or if it's severe enough at onset, like when patients first arriving, maybe start them on that, but probably refer to a specialist just to make sure that everything is good and that it's cleared up. Prevention for either one of these, whether it's bacterial or fungal, would be things like we talked about earlier as a joke, using earplugs for swimming. Not good for trying to look cool, but good for preventing ear infections. Making sure that you kind of tilt your head to let the water drain out if you do go, swimming and have your head submerged and all that, and just kind of gently bouncing your head to the side to kind of let that water drain out. And there's also some preparations that you can use, like there's like the acetic acid without the steroid that's available for you to kind of put in the ears to kind of help cause that water to evaporate. There's also one that's called swimmer's ear, I believe.
Yep.
That I think is just
swim ear, I think.
Swim ear.
I think.
It's just like a white bottle with a guy swimming laps on it, and if I remember, and I think it's pretty sure it's just plain ethanol.
It's just alcohol. The alcohol
ethyl alcohol. Yeah. So it's just there to help dry up that loose water that's in the ear. So nothing special, but also
people kill for it though. They're always wanting that stuff.
And make sure that if a patient does have it, like let's say you're working in community pharmacy and they come in with an ear infection, have them go see someone as opposed to giving that swimmer's ear over the counter. Because I have had a few people back when I was in that role, patients that thought they could use that and it would magically cure the.
Mm-hmm. It's not an antibiotic.
Yeah, definitely make sure they're reading the ingredients as opposed to the label because it's a little misleading.
I feel like it would be more preventative than if you feel like you're having what I mean. If you have water in there and you can't bang it out, use something to dry it up.
Yeah,
and then if you have an infection, it's probably going to be treated. unless it's media, and we'll talk about that, right?
I had one of my PA students. We talked about this recently with the PA students in class, and one of them kind of like raised his hand and asked me if I can share the story, but I'm sure he won't care. And he was saying that when he was younger, I think he said he was maybe like 7 or 8. He had gone tubing with some family members and stuff, and had some water in his ear, and didn't know. I guess he had taken a rough like spill, and so his water had gone up in his ear so hard that it actually perforated his tympanic membrane, and I don't even know I guess just because it's such a sensitive area, but they dropped the alcohol in his ear to try to get the water out because they thought that's all it was. And he said it was basically like a concussion grenade, went off inside of his head. He's screaming and his parents didn't know what was wrong. I was like, geez, did you ever go tubing again? He goes, it took a while. I thought that was funny. I was like, geez, that is rough. That's
terrible.
Like PTSD after just putting some drops in your ear.
Surprised that doesn't happen more often.
Yeah, that'd be rough. I guess he must have.
They probably just figure it's a bad infection or something. If he's, they don't. Yeah, might not realize that that's what's going on.
Yeah, he hit the water hard enough to where his eardrum popped, and then they put alcohol in there.
That's I imagine when I would go tubing on the lake. My dad's driving the boat. 100 miles an hour, flip you as hard as you possibly can so you half die. That's what I imagine happening.
Yeah,
and
for sure.
I probably had some busted eardrums. Definitely had some flayed skin after skidding across the water for 50 feet.
Yeah, it's freaking tubing.
Okay.
It's a fun time.
So that's Otitis Externa. So now we're going to move a little deeper into the middle ear with Otitis Media, right? Mm-hmm. So it's an infection of the middle ear. Pathogens can be a little bit different, but still recognizable. Strep pneumo, H flu, MCAT, group A strep, all those can cause otitis media. Symptoms are usually acute, which is similar to externa, otalgia, oral fullness, and possibly decreased hearing, depending on how high the fever is.
So,
or I guess with or without fever, I should say.
Yeah, can be both. So they can use the otoscope to just basically assess the arrhythmia, and just the basic inflammation of the tympanic membrane, as well as look for a bulging of that tympanic membrane, looking for any kind of pus that's built up behind the tympanic membrane. The main kind of consideration for treating with antibiotics is the presence of pain, which obviously is going to be there regardless in most cases. But on top of the pain, seeing the objective findings, including that tympanic membrane inflammation, redness, and then the bulging, especially if there's a fever present, that kind of pushes you a little bit more towards the need for antibiotics. One thing that's kind of interesting is the UK NICE guidelines. So the guidelines that they use for various disease states over in the UK recommend observation for otitis media as opposed to treating with antibiotics every single person that comes in with that diagnosis, unless their patient is severely ill or there's evidence of some kind of a complication or something like that. The presence of middle ear fluid, so just the buildup of fluid in the ear, not pus, but actual fluid alone, does not necessarily indicate the need for antibiotic use. So one of the things I was telling my students also is that might be a little bit harder selling point in the urgent care clinic to...
Yeah. Well, it's always a hard selling point to not give someone an antibiotic.
Yeah, because they come in, they're going to want antibiotics. Now, the thought process, obviously, the reason why they may hold off on antibiotics is because they want to make sure the body doesn't, one, clear it on its own, making sure that it actually needs, the antibiotics to be treated, and you're promoting antimicrobial stewardship. The bugs that we're covering for are also the ones that are involved in most respiratory type infections, including pneumonia. So we want to limit, kind of the exposure to antibiotics. However, when most Americans go into urgent care settings, we tend to be like, hey, we need antibiotics. We already know which ones to give. Just give me a Z-Pack or whatever I need and get out of my way. So we have a lot of resistance problems.
It's a tough line to toe. And so sometimes they'll say something like, because say it doesn't resolve in a certain amount of time, then they probably are going to need an antibiotic. So especially if it's an urgent care, do they just call back in and you'll call in the prescription or, blah, blah, blah. So sometimes they'll send a prescription and say, don't fill it unless, it's been this long without resolution. But I've seen that that's frowned upon as well. So it's a tough line to toe. Did you mention the Weber test?
No, I didn't. That's another.
I want to say, so the Weber test, which is like one of the things you can use to diagnose is for hearing, but you can, put a tuning fork in the middle of the forehead and kind of see if they're able to hear it or whatever. My brother was telling me when they were learning the physical exam stuff, he's in PA school. I actually tried to get him to come on the podcast because he's going to be in town tomorrow, but he's shy, so he didn't want to come on. But he was saying that, anytime you had a test like that done, they would say, can you hear this, or let me know when you can hear this, or something like that, signal when you can hear this. But you're not supposed to say that. You're supposed to say something along the lines of, let me know what you sense, because otherwise you're leading them to tell you that they can hear something or something like that. So no matter what you're testing, it's like, let me know what you sense. And then they tell you what they sense.
I think if somebody told me, like, tell me what you can sense, I'm like, what am I, an X-Men?
Right. I'd be like, well, I can smell body odor. Yeah. I can feel this. I would just be sassy.
Yeah, that'd be weird. I'd be too focused on that weird question to like even pay attention to the test at that point. Like, what's this guy talking about?
I'd be like, what do you sense? Dead people?
Yeah, for sure. I hope not. So I mentioned some if there's complications, then definitely we need to treat with antibiotics. A couple like kind of more obvious complications being like conductive hearing loss or any kind of like perforation of the tympanic membrane would lead you to maybe treating quicker than instead of observational. But also things like facial palsy, and then vertigo, things like that, and then also especially if it's much more severe where it's spread, things like meningitis or mastoiditis. Those are all potential complications of otitis media. So it's not just obviously there's going to be a lot more going on than with those last two than just some ear pain, but those are potential complications. So it would be things that if you do feel that it's spreading, things like that, then antibiotics 100% would be okay to start.
Right. And if you're starting them, then there are it depends on kind of the patient, which one you might start first. So beta-lactams are first line, amoxicillin. You can do 500 milligrams 3 times a day. And that's for kids that haven't received amoxicillin in the last 30 days. If you're treating an adult, you're going to want to hit them with Augmentin. So add the clavulanic acid on to the amoxicillin. You can still do 500 milligrams 3 times a day, up to 875 twice a day, which I think I see a little more commonly. And that would be first line for adult patients. You can also use cefuroxime, cefpodoxime, ceftriaxone, the Rocephin IM injection. That shot would be given every other day for 3 days, and usually the course of these is 7 to 10 days. The Augmentin twice a day, 875 twice a day for 10 days is like super common.
Pretty standard.
Yeah.
One thing, though, to keep in mind is if you have an older patient, if their creatinine clearance is less than 30 mils per minute, then we do want to avoid those higher doses of amoxicillin. So they'd have to use the 500 milligrams instead of the 875. So just something to kind of keep in mind. Mm-hmm. If you go with cefuroxime, then you have to consider things like antacids, or if the patient's on H2 blockers or PPIs, cefuroxime and also ceftonir is another one that needs to have a little bit of an acidic environment to be absorbed properly. And so if a patient's on H2 blockers or a PPI, then we probably don't want to use one of those two options, especially cefuroxime being the initial one we mentioned. But if they're on antacids, just as needed, make sure they at least separated by 2 hours either way. And then the other thing is, as far as cross sensitivity, because it's something that always comes up with penicillins. Mm-hmm. Penicillin allergy is a very common thing to run into. So I would encourage you, if you have access to something like UpToDate, there's a really good article on UpToDate talking about cross reactivity between patients with penicillin allergy and then that allergy carrying over into cephalosporins. And it's something that basically we usually say like less than 10% is kind of like the go-to, like the statistic that we give when we say like, what's the chances of them being allergic to both settings, or both groups rather. An even more accurate way of looking at that would be looking at the actual side chains that are coming off of that beta-lactam ring. So, for example, amoxicillin. If you have someone that has an allergy to amoxicillin, the only identical or cephalosporins that have the identical side chain or R group or whatever you want to call it to amoxicillin is cefprozil, and that's really the only one on this list of 3 that I've even ever seen in my life. And then there's cefadroxil and ceftriaxone, which those last 2 I've never even seen.
I think they're throwing cefadroxil out for pneumonia a little bit now. I could be totally wrong about that, but
okay.
I thought that name sounds familiar from something I've seen recently.
Okay, so there you go. But those are the only ones that have the identical side chain. So those, technically speaking, would be the ones you have to worry about having that cross-reactivity. And then with ampicillin, which most of us are not going to be giving ampicillin PO anyway, but there's the cefaclor, cephalexin, and then there's a couple others that are very obscure that I've never heard of before. But those are the 2, cefaclor and cephalexin are the 2 that are commonly used still, and especially cephalexin. And they have identical side chains to ampicillin. Mm-hmm. So that's really like where the allergy, like cross-reactivity kind of comes into play. So if it's cefuroxime and the person has an allergy to amoxicillin, especially if it's something like a rash, the odds of them being allergic to the cephalosporin are like extremely small. I would even say probably less than 1%.
Yeah. And I mean, that's what you run into the most is somebody had an amoxicillin allergy when they were a kid and now they're getting Keflex because those are the 2 most common. And there really is almost like just minimal risk to that.
So new providers, new pharmacists, you see that huge like warning thing that goes up might be a little overkill as far as the warning.
Yeah, I'd always just ask, and sometimes I'd get the throat closed up, something really crazy, and even still, they shouldn't have a reaction to that. But at that point, you just might play it a little safer.
Yeah, I'm definitely a little bit more safer when it comes to the throat closing up type of thing. Most of the time, it's like a little rash and some itching,
or they just can't remember, and they were just told they always had an amoxicillin allergy.
So then you respond, get over it. Right, Cole?
Just have some Benadryl close.
Yeah.
That's what I tell them.
Stop fooling around. Some alternative treatment options, if a patient, fails initial therapy, would be our ceftonir, which is our more broad spectrum, 3rd generation cephalosporin, and then our 2 respiratory fluoroquinolones, levofloxacin and moxifloxacin. And then if the patient does have uncontrolled diabetes or is immunocompromised, then Augmentin seems to be the drug of choice. And we usually extend the treatment a little bit. So instead of 10 days, maybe consider going up to 14 days in that particular patient group. And, and then not that the other options aren't used, but just kind of consider that as first line. And that's coming directly from like the Johns Hopkins antimicrobial guide that they have published. That's kind of like their big recommendation at the end of that section.
Yep. So if you choose to use Levaquin or the moxifloxacin, we know that fluoroquinolones have gotten a bad rap the last couple of years, and for good reason. So they have a boxed warning for tendon inflammation and rupture, having peripheral neuropathy that can last for months or years after using it, seizures, psychosis if it was toxic. So they have black box warnings, and then regular adverse effects as well, QT prolongation, GI upset, hypo or hyperglycemia. They can affect sulfonylureas and insulins, musculoskeletal toxicity, skin reactions, stuff like that. So not preferred in general, and so definitely reserved for later in the preferred list for this issue as well. They interact with medications, so multivalent cations can chelate and inhibit their absorption. So you want to separate the doses either 2 hours before or 6 hours after the fluoroquinolones. But yeah, I mentioned sulfonylureas and insulin. Also warfarin, they can increase the effects of warfarin. So if you have a patient on that, advise them to talk to the person who monitors their warfarin levels if they're going to start that antibiotic. And then also use caution with drugs that can decrease potassium and magnesium.
Yeah. I think it's more for the QT prolongation part of it, torsades risk. One question I thought was a pretty good one that one of my PA students asked recently was in regards to the black box warning with the tendon rupture with fluoroquinolones. They said, is that something that we'd only have to worry about really like realistically in older patients who maybe have, already have a lot of wear and tear on their tendons? So I've actually personally seen, I don't know if I've ever talked about this in the podcast, but I've actually seen personally 2 people that have had tendon rupture with fluoroquinolones, both of which were definitely not older patients. One of them was a guy who looked like a bodybuilder, and the only reason I even brought it up to him is because he was ginormous and looked like he couldn't wait to get back to the gym to lift weights. So I told him, hey, while you're on this fluoroquinolone, just make sure that you kind of take it easy. And he asked me why. And I told him about basically it can put stress on your tendons, cause inflammation, and they can even rupture. And he was like totally confused. And he like pulls up his sleeve and he shows me this huge scar on his bicep where the year prior he had the same infection. They gave him Cipro, I think it was, or Levo. And, he was lifting. I think he was doing like some kind of like back exercise where he was pulling the weight, and his bicep tendon like blew and went up, and they had to basically fish it out of his shoulder and reattach it. And so he was out for quite a while, and you could see the scar up his bicep. It was crazy. And then I know another guy who was a runner and ran all the time, totally, in good shape, not old at all, and his Achilles ruptured while he was on a fluoroquinolone. So his tendons may have obviously had some stress from running, but it just so happened to be like when he was on that. So it'd be something that it sounds like a textbook thing to say, but it definitely can happen.
I'm always concerned when I hear of a side effect that you don't hear of with other things. Like tendon rupture is kind of a weird, unique thing. I'm like, gonna be cautious with that.
For sure. That would not feel good.
No.
But yeah. And then obviously when it comes to otitis media, there's adjunct therapy you can also consider. A lot of times patients will have, maybe some sinus conditions going along with this. In fact, one of the things you may see is patients having like a sinus infection along with otitis media because they're caused by a lot of the same bugs. So if a patient's having like nasal congestion rather, using like a pseudoephedrine orally, or even like a Afrin spray to kind of open their sinuses up for a few days or so. Make sure they don't use it longer than that because it'll cause really bad rebound congestion. But using those to kind of give them some relief, help them get to sleep. And then analgesic as well if they're in pain. So acetaminophen or ibuprofen, naproxen, something like that would be fine. Usually over-the-counter strength is enough. And then the other thing to consider is if a patient finishes their antibiotic course and they're still having effusions, so that fluid kind of built up in the ear, that does not necessarily mean that the antibiotics failed. And in fact, if there's effusions following antibiotic therapy, but there's no pain inflammation still associated with the ear, then it does not warrant additional antibiotics. Now, if the effusions persist for longer than 8 weeks, then maybe you need to start looking at considering like some imaging studies, things like that, to kind of figure out maybe what's going on, or if there's, at least you can rule out other things, intracranial neoplasms, things like that are more severe, just to make sure. But a lot of times you basically just that drainage system that's getting that effusion out of the ear is just kind of clogged because of all the inflammation from sinuses and other things. And so that effusion may just be kind of sitting in the ear and not actually indicate that there's a problem or that needs to be further treated. So just kind of keep that in mind. You're looking for the combo of that along with the pain and inflammation that's really showing you that the antibiotics didn't work.
Yep.
All right, man. Anything else with this stuff?
I think we covered it all.
Every single thing you could possibly cover.
We even talked about how to, kill moles.
Yeah. That was honestly for free, you guys.
That was for free. I think we might have helped a lot of you out because it's frustrating.
Yeah. The things you learn on this podcast. So insightful. All right, y'all. So thank you guys so much for listening. If you have any questions, make sure you send us an email, or you can reach us on any of the social media platforms. You can also text us directly. And in fact, those of you who have sent me texts over this weekend, I apologize if not gotten back to you. I have 3 more that I have to respond to. So I will answer your questions soon. So I don't think I forgot about you. But the number is 415-943-6116. You text us directly and we'll get back to you as soon as we can. And then, if you do like the podcast and enjoy it, make sure that you subscribe on whatever platform you like. Leave us a comment. That helps a lot. Check out the YouTube channel as well. We have the video versions for not all the episodes, but some of them up there. And we're hopefully going to be doing some cool stuff with video here pretty soon. But if you have suggestions or anything like that, or you have somebody that you think would be a good candidate to come on the podcast with us, definitely, reach out to us. We always want to look for new opportunities with guests and whatnot. So thank you guys so much. Y'all have a great night. Take it easy.